Today we have our esteemed guest here, Dr. Nachiket Mor and Dr.KU Natarajan. So we'll be talking about how this new technological advancement is, being implemented, or what is the future in the sector of healthcare. All right. So my first question is to Dr. Nataraj. So AI is now assisting doctors in diagnosis. So, what is the future? I mean, how is this being done? Should we be concerned?
At the outset, I thank the organizers for having invited me to be part of this very interesting session, especially in the light of seeing the recent advancements in the field of medicine. So your question is regarding what is the future in terms of artificial intelligence?
So, AI is helping doctors in diagnosis. How reliable are these diagnoses? Should we trust them?
Artificial intelligence is basically based on machine learning. We give raw data about patients, the patient's profile, risk factors, and investigative tools like X-ray, imaging tools like CT scan, MRI, laboratory investigations, so on and so forth. So this machine learns over a period of time, seeing thousands and thousands of such patient data, and it helps in making a diagnosis. What a doctor will spend hours together going through multiple things. You give some raw data, the machine analyzes by its own knowledge and tells us the diagnosis. And we have, for example, one of the conditions in cardiology. I am a cardiologist. There is a condition called heart failure, where there is a defective pumping of the heart. We call it left ventricular dysfunction. So you give an ECG to artificial intelligence program. It has learned over a period of time, even without doing confirmatory tests like, for example, echocardiography, with a simple ECG and some few data provided, that the artificial intelligence by the machine itself tells that this patient is likely to have left ventricular dysfunction. What is more interesting is it does not diagnose after the left ventricular dysfunction has actually happened. It even predicts. It tells this patient is likely to develop left ventricular dysfunction. Let's say, for example, 25% chance of developing left ventricular dysfunction in the next 2 years. So it has got a lot of predictive value. And this predictive value's accuracy has been validated in trials. For example, Mayo Clinic in the US is one of the pioneering centers which does a lot of work on artificial intelligence. So with a simple ECG, it can say that this patient is likely to develop left ventricular dysfunction, or this patient already has left ventricular dysfunction. This patient is at an increased risk of stroke. So with simple data, in quick time, it's able to not only diagnose, it can also predict. So artificial intelligence is quite reliable, provided it is validated and it is judiciously used. So definitely it is, if you ask me whether it is reliable, yes, it is reliable. When is it reliable? When it is tested in a big population and validated. And a lot of conditions like stroke and left ventricular dysfunction, we now have results of trials which show that it is quite reliable.
Yes, thank you. My next question is to Dr. Nachiket. How is AI being implemented? So AI has, Dr. Nataraj said, AI has a lot of predictive capabilities. So when it comes to population health, how is AI being implemented? Especially, I'm interested in low resource setting, because AI is quite resource hungry. So how is AI being implemented in low resource settings?
Thank you. I think it's an important question. And what sir is saying, is that the foundation of AI is actually quite sound. If the data is used well, if the analysis is done well. If we start with that reality, the situation we have in a country like India is that in a primary care setting, particularly in rural areas, now Kerala is unusual that it is largely urban, but in many states, when I was the head of Gates Foundation, we focused on Bihar and UP, for example, there is simply no medical capability available. Yeah. And even a young person who is from the village, happens to get into a good medical college, never comes back to that village. Mm-hmm. Yeah. Which means we now need tools that allow a locally available health worker to do the kind of diagnosis that are important. The reality is that that can change. One example we were discussing earlier is ultrasound. Because of PCP NDT, we are not able to use ultrasound in primary care settings. Worldwide, if you go, there's a tool called Butterfly, for example, that is gradually replacing the stethoscope. People are no longer using the stethoscope, they're just carrying Butterfly with them, and they're getting an ultrasound image that can be used. St. John's Research Institute has already a prototype. Philips has a working prototype in which I have a screenless ultrasound. So I don't see the image, I cannot tell the sex of the baby. Right? In any case, the health worker has no training. Even if they saw the image, they can't use it. But now with that help, I can actually look at, for example, if there is a palpable mass in the breast, and I need to understand, is there vascularity? Is there a blood flow in it? I can use an ultrasound to figure it out. If I need to understand something is wrong with the kidney, if there is something wrong with the liver, something wrong with the prostate gland, I can do that with the ultrasound in frontline settings and make that information available at the back end. Clearly, there is a lot of power in the tools. There's also, one component of AI is these large language models. If you look at mental health, right, and there are companies like Visa, for example, that are already using it. My own view is that if I look at the protocols of treatment, they have to follow standard practice. You can't on the fly make up a protocol on how to diagnose cardiac disease or mental illness. That you need RCTs, you need standard techniques to do it. But what is the patient saying? That is sometimes hard for you to interpret, right? Unless you have an expert. Let's say somebody has had a bereavement in the family. Now we know grief is a pathway that we must get into. But from what the patient is saying, I miss my grandmother, how does one understand that this is a bereavement grief pathway versus she lives in Kochi, I live in Trivandrum, I'm not able to see her? That's also missing. Large language models are able to address this issue. They're also able to address vernacular, multiple languages, and invoke the right pathway. I don't remember the numbers, but from last recall, I think Visa has 2 million pathways. Which pathway to go down, AI can help a lot, and we can then make these tools available in primary care settings in a remote area. Clearly, lots of opportunity in primary care settings, and later on I can talk about public health settings as well. But even there is a lot one can do.
So he was talking about large language models, ChatGPT, DeepSeek. So it is often recommended by the doctors that, not only doctors, every expert say to the public, do not Google your symptoms. That's a common thing that we've been all heard. Do not Google your symptoms because it might create unnecessary panic. I can give a few examples. But large language models, as he said, has a capability to understand, ask follow-up questions to, it might feel like, this guy knows what he's saying, has the potential to make believe. Okay, so based on this pathway, do you think these tools make healthcare a little less personal, or somebody should I know this is a controversial question, should a public go to prefer a large language model over human doctors? Will that make healthcare feel less personal?
Actually, this is not a controversial question. It's a very relevant question. Will technological advancements take away the role of a human relationship between a doctor and a patient? Is exactly what you're asking. Whatever be the developments in machine learning, artificial intelligence, Google wisdom, so on and so forth, finally medicine, as you all agree with me, is more of an art rather than an abstract science. At the end of the day, a patient, a lot of times it appears as an exaggeration. The patient says, I see a particular doctor, half my illness is gone. He does not have any randomized controlled trial to say that what the patient is saying is true or not. But as somebody who has practiced medicine for the last nearly 40 years, I can tell with reasonable confidence that there is definitely a contribution because of this relationship between a doctor and a patient. Like any walks of life, there is always a relationship. No matter whatever artificial intelligence comes, machine learning comes, diagnostic capabilities are made by machines rather than doctors. It finally boils down to the relationship between a doctor and a patient. Artificial intelligence may suggest something, but it may be something else in the patient, which a doctor by his clinical acumen can pick up. Machines cannot replace human beings in any walk of life, and so is medicine. In medicine in particular, probably there is a human interface which is far more than driving a Tesla car in the road without drivers. So medicine cannot be without a human interface. Not because I am a doctor, I am saying. I have been a patient too, to another doctor. When I have an orthopedic problem, I go to an orthopedic surgeon. It is not treating an X-ray, it is not treating a CT scan or an MRI. Finally, you have to use the data judiciously, convey the right meaning to a patient in a humane manner, which is quite eroding in today's time. Everything is artificial, everything is being, whether it is intelligence or whether it is reliance and technology, etc. The human contribution to every field in life, particularly medicine, is going off. I personally feel, I'm very happy that you asked that question. There is still a solid role for humanness and human interface. Whatever happens in the field of medicine in terms of developments in artificial intelligence, so on and so forth.
That's a great answer. Thank you. Coming back to Dr. Nachiket,
Thank you.
it's about financing. So AI in financing. So like as I said, AI is an expensive technology. At least for the people in the back end to implement these models, it's very expensive. So how do you? So based on your experience in financial inclusion, how does this low resource setting rural area can get equal healthcare as urban areas? So how do you think it is going to go?
So, two comments. One is I just want to build on what Sir said, just to add a little bit. While I completely agree with Sir that there are many components of healthcare that need a human interface, if I look at rural or primary care work, not specialist work of the type he does, medical errors are quite high. There is, if you see during COVID, one of the reasons why India was one of the few countries that saw micromucosis, because our doctors were prescribing steroids without fully understanding the implications of it. You saw the ivermectin. The manufacturer is saying, don't use it. Large trial out of UK is telling us, don't use it. Yet our doctors were prescribing it. I was involved quite closely in COVID relief. There was, what they call, laundry list of medicines. You go to a doctor, the prescription runs into 2 pages. They will add this medicine, that medicine, there is a steroid also, an antibiotic also, there's something else also, just in case, right? These errors have to go. We can't be running medicine in this kind of way, right? What is starting to happen, I think a good combination of the human and the machine. For example, we now know that one of the reasons why a state like Kerala, for example, is, despite a very good health system, is struggling with an enormous burden of diabetes, right? In fact, what I was telling you earlier, my fear is by 2035, you will have an epidemic of amputations in the state, in some of the richest districts. Every home an amputee. Why? Untreated, undiagnosed diabetes. Right? Countries like Iran have discovered the only way to address it is not prescription and treatment. A simple blood sugar test, random blood sugar. I don't even need fasting blood sugar. If I have a random blood sugar of 300, right, that tells me I have diabetes. Right? 200 is the cutoff, 140 is the cutoff, but there you might need more fine tests, right? But people are not adhering. And for that, a human interface is very, very necessary. But for the basic diagnosis, for the kind of data that there is,
Screenings at least.
Screenings, even ongoing. See, screenings, again, this is a little bit of an issue. People have made executive health checkup and once a year checkup as the gold standard. The reality is most people don't go for it. I've worked in many companies. 3-4% of employees benefit from that. It should be integrated into primary care. When I show up with my doctor with a cough, my BP should be also checked. If I have not gotten colonoscopy done, the doctor should tell me, sir, I will treat your cough, But what about your colonoscopy? Can we schedule an appointment right now? Instead of saying once a year you show up for it. And there, this idea of the digital twin, which is carefully maintaining your information, can become quite an important assistant to the doctor. My, belief is, over time, while the specialists will continue to have, because there I think the art nature of the work becomes much more dominant. I think in primary care settings, doctors will start to assist the AI and the frontline health worker, not the other way around. Because then one will have to worry much more about referrals, much more about, what to manage with comorbidities, multiple comorbidities, how to go about dealing with it, right? That's, I think, the issue. On your question of expense, see, the good advantage India has is we have numbers. Yeah. Yes, for a developer, like you, investing the resources needed to build models.
Yes.
But we can throw volume that no other country can.
Yeah.
Right? Which means even a very expensive technology with no variable cost, with a fixed cost, the variable cost can collapse to near zero.
Yeah.
If you have a good Chem 7, KX21 machine for running your diagnostics, I'm told a CBC can become as low as 2 rupees.
Really?
Yeah, you need volume, of course, to throw at it.
Yeah.
But to do a CBC at 2 rupees, no other country can manage it. So we are actually in a very favored position to give return on investment. Now you're right, who will put the investment in? And there I think, perhaps the government, perhaps large foundations, it's their role to anticipate the future, work with doctors like Sir to say, can we build the back end, bring researchers like you on board and help us, with the back end technology. But I think the ROI will be pretty good. And I don't need to then worry about rural or urban. Every human being in India should be able to get the benefit of the best evidence-based thinking in psychiatry, in cardiology, in, kidney disease, wherever they are.
All right. Thank you. Do you want to comment on what Dr.
No, I cannot agree more with what Sir was telling. See, in places where there is no access to medical profession, AI-based learning can be an excellent screening tool, which can be verified by a doctor sitting at a distance. Doctor or a healthcare professional for that matter, sitting far away, which was very helpful during the COVID pandemic. Sir will agree with me. So that is one important role of artificial intelligence and machine learning and remote medical care offered to places where there is no access to doctors and healthcare workers. That is number one. In places where there is an ample availability of medical professional, as he said, it is a mutual collaborated role of machine learning as well as natural intelligence of the medical professional. As he very correctly said, the machines can actually temper a doctor also. He is absolute. I didn't say that, he said it in as many words. As he said, doctors can make wrong diagnosis, they can over-prescribe. So these machines can actually be a check on the doctor, actually. It is definitely better than Google wisdom. So a machine, the diagnostic ability and personalized medicine treatment that I'm sure you'll ask about it, definitely it helps. So one cannot replace the other. Machines cannot replace human beings. Human beings cannot say, I can be without machines forever. Both are wrong. It should be a balanced utilization, a judicious utilization of both machines and human interface.
Thank you. So my next question is about personalized medicine. So let's say people with certain genetic factors and lifestyle factors. So how is the effect of this artificial intelligence when it comes to precision medicine? So like imagine Dr. Nachiket and we, like myself, was your patients, and we have similar symptoms, but the course of treatment for you would be different. You'll consider a lot of factors. So how exactly in precision medicine AI is being used or can be used?
Already now, even without the advent of artificial intelligence, precision medicine is already being practiced based on the genetic profile of a person, based on the presence of a particular mutation. For example, if you take a condition called hypertrophic cardiomyopathy, you must have seen athletes dying suddenly. It is because of a thick heart muscle. It's called hypertrophic cardiomyopathy. In some people, there is a high risk of sudden death in this condition, whereas in some people with this condition, there is no high risk of sudden death. Both patients belong to the same profile. We do a genetic analysis and find out the incriminating mutation in this condition. If that mutation is positive, this patient is at a higher risk. If that mutation is negative, the risk is lower. This is, I understand, by genetic analysis. Now, for example, our institution is part of a study using AI just from the ECG. You can predict the risk of sudden death in that patient. Now we are resorting to genetic study, cardiac MRI, 24-hour ECG monitoring, history of sudden fainting episodes. We use all these factors to our advantage and then say there are multiple risk factors, you are at a high risk of sudden death. The machine learning by a simple raw electrocardiogram, which sir, as he correctly said, is a very inexpensive tool. So over a period of thousands and thousands of analysis of the raw ECG, with a simple ECG, the machine is able to predict and say, here is a patient with increased risk of sudden death. So if it is validated, you can circumvent doing all expensive investigations. So one ECG will tell you, both of you have the same condition, but you have a sudden increased risk of sudden death, whereas patient B does not have. So AI definitely has a role to play in personalized medicine. That is going to be the future. So as you correctly mentioned, 10 people sitting in the audience, all 10 have diabetes. One patient may respond to insulin. The other person may respond only to lifestyle modification. Another person may respond to one particular drug. Another person may not respond to another drug, so don't waste your money on that drug. So the future is going to be that. So doctors should judiciously use information learned by artificial intelligence. That is going to be the future. Already it is there, and artificial intelligence will go a long way to further simplify the process.
Thank you. That's a great answer. My next question is for you, Dr. Mor. So, like, this is about policymakers. A person like you who are working in the ground, what kind of changes do you expect from the policymakers for the better implementation of these technologies in the ground actually? So how do you?
So two things. One is to build on what doctor said. You know, there is another emerging field called precision public health. Right? One is precision personalized medicine, but the other is precision public health. Let me give you some examples. Yeah. Right? Let's take, for example, malaria. Right? Fortunately, it's on the downturn in India. Only Odisha has a pocket. But with climate change, we're expecting a resurgence of the Anopheles mosquito. Right? And of course, there are others that we are starting to see, dengue, others that are there. With satellite data, India has the good fortune of having geostationary satellites that are able to map our country properly. Right? We now are able to tell that farming patterns, right, or forest borders, deep inside the forest there are many mosquitoes. Anopheles cannot survive as well. But on the edges of forests, where human beings are also there, the selection favors Anopheles. Right? So you get malaria burdens. With machine learning and satellite data, we can now tell where is the risk high of malaria and where it's low in precise geographies. And we don't need to now say we'll put quinine, everybody will start taking quinine or put DDT in all the water. We don't have to do that. We know exactly where to go to figure what is going on. Right? This is information that we did not have earlier. And my own sense is that the ability of machines to analyze images, even radiologic images, CT scans, MRIs, there are over 5 lakh pixels in a single CT scan. A human eye can do a good job, trained human eye can do a good job, but approximate job. The precision with which a machine can read every single pixel, which is what sir was saying with the ECG, right? Because obviously the ECG seems to have the information that sir needs, but the human eye is not able to tell what that information is. A machine is able to do that. In public health, that can actually make a lot of difference. On the policy front, my own understanding is the governments actually are quite excited about these technologies because, it has both brand value, you look modern and you're doing modern things. I think what is needed is perhaps more support for researchers like you on the back end side. Because I feel there is some temptation to say the West will develop this, we will simply use it. But actually, that's not turning out to be the right answer. The best ideas for our work in India will have to come from us. Right? The kind of forest density Kerala has, Odisha has, we have to worry about our bat populations. Now, what is going on with bat populations? Right? America may not be as interested in that problem, right? Because they may not have the kind of concentrations of bats that we have. Right? We will have to figure out a lot of our own work, which means primary investment. And this idea that only public sector labs will develop everything may be a little bit dated. We'll have to harness the capability of private institutions and public sector labs to use this, which means back-end investment will become quite important. Also, from a policy perspective, I think we have to worry about, biases. We have to certainly worry about hallucinations. So you can't hand over, as Sir has been pointing out, quite a bit. You can't hand over, technology, the problem to the technology, because it may be hallucinating. The same Google problem that we have, when you Google a disease, 20 things come out, which is right. We have no idea, right? Only a doctor can tell, this is useful information, this is rubbish information. We will look at the top, but actually the top may be the worst answer. The only reason it's at the top is many more people looked at it, which is why it came to the top. It is not because it is more right that it came to the top, right? Now, these are things that policy will have to intervene in, because we can't allow, there's a lot of hidden biases in technology, particularly in AI. And, you might say, where is this available? A simple thing like the pulse ox meter, it's sensitive to the skin of the color of the skin, right? If you're not able to get skin color right, you find that the diagnosis doesn't work well, right? Dark-skinned people might get a very different answer than light-skinned people. And now many people are trying non-invasive testing of hemoglobin, but that's entirely color, right? If you don't correct for this, you'll end up with biases that we have imported from the West. Again, policy will have to, there's a lot of bias against women, right? If you see, the world around us, airbags are not designed for women, car seats are not designed for women. There are a lot more fatality when there is an airbag deployment in a car where a woman is driving or a woman is a passenger than if there are men as a passenger. Because the whole thing is designed for the man and not designed for the woman. Right? Okay. These are issues that the government policy will have to correct. Because on its own, technologists will get carried away by the value of the technology. They won't bother with some of these concerns.
Yeah. So, thank you. Bias. That's a powerful word, actually. So, we've been working with image analysis quite a lot. Models like UNIT used for medical image segmentation. Let's say you pull up a CT scan and you have to ask the model to create bounding boxes around certain anomalies and something. But the problem is, these models are heavily trained on data from the West. Available models are. So, do you think that poses a certain threat if being, implemented on other parts of the world? What's your take on this?
This is not only with regards to artificial intelligence. Let's say there is a new drug which is coming, and a randomized trial is being conducted to see whether the drug is useful or not. How do they do it? You have 1,000 patients. In 500 people, you give the drug. In 500 other people, you don't give the drug. You give something equivalent of a drug, but it's not the drug.
Placebo.
And you follow up these patients over a period of time to find out whether the drug made any positive impact on the patients in whom it was given. These drug trials also, let us say it is being done only in Europe and the US. The data you need not mechanically extrapolate and give it to our patients. That is how now all trials involve multiple centers in multiple countries involving multiple races. There should be representation, and also the genders. So there should be an equal representation of all sections of the population for you to generalize the results of the particular study. Same is the case with artificial intelligence. If I told you about the example of hypertrophic cardiomyopathy, where from the raw ECG, the machine is able to predict, we also contributed 600 patients to that particular study. It was a multicentric study from 2 big universities in the US, and one was our own center. So that's why you should interpret the results of a study, whether it is for a drug, whether it is artificial intelligence, for that matter, anything in medicine. You should also look at the population in which it was studied. You should not blindly extrapolate the data where your local population was not represented. That is the importance of global participation of every clinical trial, and that applies to artificial intelligence as well. Otherwise, there is definitely going to be an element of bias, as he said. So if one particular population is not included in that particular analysis, that results you cannot use it for that particular population. So that, I hope, answers your question. Yes. There should be global participation of any trial, including artificial intelligence. A lot of data should be contributed to machine learning from our local population, which is eminently possible. You don't actually have to look into the West to learn about artificial intelligence. The artificial intelligence space in countries like the US is largely manned by Indians who went from here to the US. So when Indians are contributing to data in the West, we Indians can contribute heavily, and the development in artificial intelligence in the Indian context is enormous. So you can do local studies, you can do machine learning. It is now, artificial intelligence is one of the subjects in engineering colleges now. Yeah. There is an MTech only on artificial intelligence, like robotics, artificial intelligence. So the future is definitely very bright for artificial intelligence, especially in a country like India with the large population, as he rightly mentioned. We are the second most populated country in the world. So do any research, we have enough and more data. So we shouldn't be looking at the West for our intelligence. We should use our local population to learn these things from, and that will be even more useful than what we learned from Western statistics.
Okay. One more question to you. See, AI is everywhere right now. Wherever you look at, there is some part of AI in the technology. So how does it matters in medical education? How should medical students, look out? How should medical professors, how should they embrace AI? Should they learn how to work alongside AI, or I've seen quite of my professors are a bit skeptic. When I go to the results, I know where this came from. They'll be like, I know where this came from. So, what's your take on that? How should students?
It's a very sensitive question and a very touchy question also. If you talk about AI to a former professor of medicine who is 75 years of age, he will say it is absolutely useless. Because that man, all his life, has been talking to the patient, taking a detailed history, using a stethoscope. Now stethoscope is an ornament. Recently I saw a picture where somebody is examining with a stethoscope on the neck rather than in the ears. For a photograph, for a photo op session, a doctor was posing. The stent was not even in the ears. So what I'm saying is, AI definitely makes a role. When I studied medicine exactly 40 years ago, we didn't have artificial intelligence. Our professors were very strict. We are supposed to maintain ethics in the classroom. We are supposed to talk in details to the patient. In a way, we get maximum information without hurting the patient. We have to get his permission before you talk to the patient, examine him, use your stethoscope, have differential diagnosis. As he said, 10 diagnoses, of which is most likely. And that kind of discussion we were all used to. So suddenly you bring in AI to me, I feel really bad. So much of natural intelligence I have gained over 4 decades of practice and learning consistently and thousands of patients. Suddenly somebody comes and says you don't have to do anything. Just feed in some particular data. The machine tells you this is hypertension. Beta blocker will be more useful in this condition. Check the renal function. This patient could have renal failure. So it's a big challenge between what I have learned. So in other words, as we have already been discussing, every field, including doctors, have to be kind enough or humble enough or modest enough to understand the benefits out of technological. You shouldn't be very rigid. So as you correctly said, now that these things are coming into vogue, the medical education should impart knowledge on artificial intelligence. How to make machines learn, how to make use of what machines have learned and given you information. That should be part and parcel of medical education for the present and for the future. Because Unfortunately, clinical medicine that way will slowly die. But that is where the importance of human interface, which we have already discussed. So to answer your question briefly, artificial intelligence should be in the medical curriculum. Because you cannot, it is really useful. Why should you not use something which is so very useful? So our new generation of doctors should be abreast to technology. They should use artificial intelligence judiciously and interpret the results accordingly and use it for patients' benefit. So it should be part of medical curriculum.
Okay, thank you. Dr. Nachiket, do you want to comment on that?
No, I think what Sir has said is really quite important. But there's something basic that is also a bit of a challenge in India. I'm a part of a group that tries to build research consortia. It's a government group for blood cancers. Right? Today, and this is such a stark difference between the West and us. The use of electronic health records in India is nearly zero. Only some private hospitals have it. Right? Even those don't always consistently have it, right? Which means everybody is laboriously writing something, right? I've met doctors in the US. They don't remember how to use paper. They don't have any paper in the hospital at all for 2 decades, 3 decades. And one of the reasons why it becomes hard to do research and participate in multi-center trials, we can't supply electronic data. Why? Because we don't have it, right? And I think the real source of the problem there is medical colleges. Medical colleges should take away paper completely. Force students to work on electronic means only. Because part of the problem with paper is, A, it is paper, so you can't actually tell what is going on with AI or anything. Right? Second, there is information in patient history even without AI. I look at the BP pattern, I look at the sugar pattern, I look at the glyceride patterns. There's a lot more analysis I can do. But if I'm not even looking at the screen, I'm only looking at my piece of paper and whatever random papers that the patient happened to have brought in, whether he forgot something, didn't forget something, who knows, right? I think this is an enormous gap that we will have to solve. And I would say a state like Kerala, for example, right, in the public sector, in the private sector, right? I mean, I give you a simpler example, not AI related. You go to any tertiary care center in the state, any, it is full of patients, right? It looks, go to AIMS and all that, you find that the whole country is sitting there. 90% of the patients are there for a primary care issue. We should implement gatekeeping. They should not be coming to these tertiary care centers unless a primary care facility has referred them. But with that electronics, you can't do it because patient records have to flow. Right? So that's a big gap I think we will have to solve if we're going to make this work. Right? But otherwise, clearly, many of the points that Sir has made, I don't want to repeat, as a real value to us participating in some of these conversations and making this happen.
Okay. So, last question to you. Actually, both of you, you have enormous experience in public health and personalized, clinical health. So, what do you think the next big thing in your healthcare is in terms of what do you see? How do you see, this healthcare in 10 years in the future?
See, my sense of what is happening is, and if you look at the budget announcement as well, the government is finally starting to see that this idea of optic fiber on a nationwide basis is no longer something. The Universal Service Obligation Fund has been sitting on money for the last 20 years. Every year they get more money from when we make a phone call, a little cess goes to them. I think the current budget is, current cash balance exceeds 1 lakh crore, right? They have to use that money to make sure that the country is wired fully with broadband because medical images are fact, right? You need to communicate that data back and forth, right? Let us assume that gets done over a 10-year period. I see a golden age of healthcare coming because I think we in India can bring extremely low-cost manpower at the front end. With the help of technology, our health workers will be able to offer the best possible diagnosis right at the front end. We manufacture every drug that is it. The entire 364 drugs in the essential drug list of WHO is manufactured in India by Indian companies at extremely low cost. Yes, the very latest patented drugs are not available as easily in India, but the base drugs, which are needed for 90% of our disease burden, are available. You combine these two capabilities with the fact that the human being is sitting in the homes of patients, persuading them to take the medicine, change their lifestyle, have less sugar, have less salt. I think we can deliver healthcare outcomes that will be second to none in the world. Of course, in tertiary care, secondary care facilities also, sir will know better what can be done there. But I see really at the primary care level, this technology becoming transformative.
Dr. Nataraj, so we have our title, Pacemakers to Microbots. So how does the future of clinical medicine looks to you?
I'll spend 1 minute on what we already discussed, if you don't mind.
Yeah, sure.
This is regarding the electronic medical records.
Yeah.
I come from an institution which embraced electronic medical records
EMRs.
much earlier in the country itself, one of the centers which implemented. But then, and the current generation in terms of training in this, they're pretty good at it. My son, for instance, he can work on gadgets. He also did medicine. Most of the books, he actually had soft copies on electronic gadgets, iPads and so on. We belong to the era where we used to underline, mark with fluorescent markers, put extra papers and write special note what I have learned from this. And our book will be double the size of the original book itself. But electronic medical records also takes away the humaneness. See, for example, a patient is sitting to my left. I am sitting here and typing. What's your name? So there is a lot of disconnect between the patient and the doctor because of it is useful. In other words, every technological advancement is pretty useful in making a diagnosis, making a treatment, and you can avoid writing on paper. So many advantages. But then, no technological advancement should take away the human component. That's what I wanted to say. A lot of patients miss. Previously, we used to talk to the patient. We even ask about their family members. How's your daughter? Last visit, he would have told about his daughter going to get married. I will ask them, how was the marriage? How is she doing? Where is she living? All this matters. EMR, machine learning, etc. takes away all these things. However, one should embrace technology. You should have an intelligent mix of everything. So as regards your question, pacemakers to microbots.
How does the future, another comment on that, like I believe EMRs are the way to go. Like I don't have anything personally against doctors, but I think it can eradicate a lot of physician errors. Like every doctors are humans, and humans are prone to errors. And let's say a misprescription of a particular drug where it should not be. EMR software doesn't allow you to do that. So I think that, now coming back to my...
It is very, very useful.
Yes.
All these are useful. It's useful. But should be used intelligently with the human component. That's all I wanted to say.
Sure.
With regards to advancements, the future is very bright in the field of medicine. Technology has come to a big rescue. For example, 100 years back, if somebody had a low pulse rate, they will drop down dead. There were no medicines to increase the pulse rate. Now, as your topic suggests, pacemakers. Pacemakers have revolutionized patients with low heart rate. It's an electronic device. You implant it, works for 10 to 12 years, and the patient will have a guaranteed heart rate of 60, 100. It mimics the normal heart. So technology has come to the rescue of patients to a large extent in the last 50 years or so, from gadgets like pacemakers, angioplasty, stenting, provided it is used in the right patient, in the right way, for the right reason, etc., etc. We won't go into those details now. So, and artificial intelligence, as we have been discussing since morning, will definitely help in making diagnosis, precise treatment, etc. And it's very relevant in Indian context, as sir has been telling right from the beginning. We have a large rural population. Majority of Indians live in rural areas where there is no access to healthcare. There are patients, there are some ASHA workers. They go with chest pain, no diagnosis. So if technology can help in making a diagnosis by medical professionals sitting at a distance, by knowledge gained by artificial intelligence, it will go a long way in a country like India. So precision medicine, diagnosis, treatment, and keep a check on the doctors also, as he mentioned. So it's all a balance between everything. So the future is very bright, provided we use it right and in an intelligent manner.
Okay. So thank you. We can take some questions if the...
Bias, as you told, a very important term there. Now, when you have data from alternative medicines also pouring in, now how do you go in now with this predictive data analysis? So that's one thing which I would like to know. And second is, with predictive diagnosis, like what Dr. Natarajan was saying, like something which can be predicted 25 years from what can happen to a person who is just an youngster now. Now, are there any policies being framed out for insurance sector when this predictive diagnosis is being brought in? Now, where do we land up then?
To answer your question, we should also feed such data for machine learning. That is number one. What is not fed for machine learning obviously will not be useful in terms of knowledge gained by artificial intelligence. So all that data also has to be fed in. It makes it very, very complicated, as you rightly mentioned. So maybe you can answer on that particular thing. Alternative fields of medicine, inputs which have not been fed rightly in the current artificial intelligence space, the bias created.
I mean, clearly one direction in which alternate medicine and modern medicine have come together is in the discovery of drugs, right? There are many drugs today. Aspirin, for example, comes from the bark of a tree originally. Artemisinin, for example, was in Ayurveda, we have this thing called a kadha, the black, ugly tasting thing. Artemisinin came from that. And there is still, of course, we found chemical means of producing it, but it's an original drug. Vincristine, a very powerful anti-cancer drug. The vinca flower, common flower, right? The alkaloids from that. How does one map this information set? There is vast literature in Ayurveda. With machine learning, we will be able to learn more quickly. And the good thing about the modern medicine field is, because traditional medicine has an empirical basis going back hundreds of years, its approvals are fast-tracked. Because you don't have safety concerns of the type that you would have of a new chemical molecule. You can present data. Of course, you still have to go to the trials, but the movement is much more quick to do it. Now, can we apply the same thing to therapies? Can we apply same thing to insights of people? Clearly, a lot more, both positive and negative. Right? For example, one of the fields in which I work in is mental health. Mindfulness meditation. There is some evidence of harm starting to emerge. As you start to build large populations, that because modern medicine embraced mindfulness, a lot of people started to enter mindfulness for cardiac work, for mental illness, etc. We now know that in a small proportion of population that was already depressed, already suicidal, mindfulness may exacerbate the problem. Machine learning, artificial intelligence can help us identify these problem areas fairly quickly so that we can start to use the data in a very responsible way. So we don't know what the future will be like, but there is a lot of opportunity, and I think there is a lot that we and our systems of medicine, which are very mature and have been around for a long time, as their data starts to get input into the overall machine learning algorithms, we may come up with integrated medicine, integrated approaches that are quite powerful. The other question you had was in the insurance front. One of the challenges of India, amongst the many, is that Indian insurers are permitted to reject applicants on the basis, in fact, only on the basis of pre-existing conditions. Elsewhere in the world, this is illegal. Right? You may reject the patient on other basis, but not on pre-existing disease. Right? Unfortunately, what is happening there is this turned into a bit of a vicious circle. So no patient will declare himself sick. They will apply saying, no hypertension. They are 55 years of age, right? But 80% of applicants are saying they never had hypertension, never had diabetes, never had, it's a wonder of the world. How is it such a large population of 55-year-olds are all with no pre-existing condition, right? And then insurers rely on rejecting. This has to change. And new judgments of Delhi High Court, for example, are starting to force insurers and the insurance regulator to re-examine how to go about doing it. And good thing again is, one benefit of being a laggard country on some of these fronts, we can learn from others. Germany, for example, is one of the leaders in trying to understand how to build an inclusive insurance system that doesn't reject anybody, doesn't charge more to people who are pre-existing conditions. Because the reality is, from a, womb to tomb, at some point we will all develop some disease. Nobody just dies. Most people die, sadly, of a heart attack, right? But at some point, this will happen to us, right? What happens to the insurance after that? I think laws will have to change. This is where the whole policy direction will have to go to address this issue. No, so I'm saying once you know, for example, if I have a genetic mutation that makes me susceptible to a rare disease, right? Can an insurer say, I will not insure you? Currently they can. This should be made illegal.